podium. She is the four-time winner of the best APP presentation at these society congresses. She's been an integral part of building the trauma research program at our institution. She has presented and published multiple impactful papers focusing on VTE, chest wall injury, thromboelastography, and the management of low-risk brain trauma. She was the first APP appointed to the rank of assistant professor at the Intermountain Health and has served as the Trauma APP Fellowship Director, Research Director since 2017. She strongly advocates for APPs in trauma and surgical critical care on a national level and is passionate about improving the care of trauma patients through the advancement of physician APP partnerships. Without further ado, it's my distinct pleasure to introduce Annika K. Annika, you ready?
Oh, okay. Thank you, Dr. White, and to the Congress for this invitation. This podium has always been a special place for me, representing an important opportunity, another door opened, a culmination of hard work. But this invitation was quite a surprise. It's really beyond a privilege, beyond humbling in words to be up here with 45 minutes to tell a story rather than the usual 7-minute scientific presentation. And speaking to a room of surgeons, I want to start with my only relevant disclosure, and that is I am not a surgeon. I am a PA, as Dr. White alluded to. I'm a physician assistant, most recently known as a physician associate, advanced practice clinician, advanced practice provider, APP. I'm a PA. I had no research or PhD training. I am just a PA. And I say just, not to belittle my profession, of course, but really to illustrate that my experience and accomplishments had little to do with my PA school training and everything to do with the team and environment in which I have worked. I'm going to share, talk about two great passions of mine in a kind of tale of two stories. First, the power of physician APP partnerships in advancing the care of surgical patients. And second, the power of asking questions as told through my experience in VTE research. But first, I must acknowledge my love of the trauma team in an ode to the trauma team. Growing up a basketball player and a diehard sports fan, being a part of a team has always been a place where I've thrived, right? Being part of a machine working toward accomplishing a greater goal, and what a machine a trauma team is. Trauma teams must work on, yes, a foundation of tacit knowledge, but importantly, leadership, confidence, determination, trust, cohesiveness. Sometimes we win and sometimes we lose. And when you endure that with a group of people, they become family. Trauma surgeons have inspired me from the beginning, leading teams that are adaptable, unflappable under pressure, ready to go at any given moment, experts at making difficult decisions in a matter of seconds. I've learned that trauma teams, we show up. We never say no. We never shy away from a complicated situation or maybe a simple one where showing up is actually the best thing for the patient. I want to talk about my team, which is really why I'm here. I work at Intermountain Medical Center, which is a level 1 trauma center in Salt Lake, serving the Salt Lake Valley and greater Intermountain West region. We see about 4,000 to 5,000 registry patients per year. We are an APP-led service started by this visionary trauma surgeon, Dr. Mark Stevens on the left, who was clearly ahead of his time in the late 90s. I'm actually like the young one on the team. Our APPs are involved in all aspects of trauma care, from the bay to the door. We really practice at the top of our scope and have roles including team lead in the trauma bay for activations and resuscitations. We independently perform bedside procedures. We have an APP-led trauma floor and a closed trauma ICU team, surgical first assist. We have an APP-led massive transfusion response team, which I'll talk about in a minute, trauma clinic. And importantly, I think uniquely, we have APPs in protected administrative roles, including PI, trauma research, EMS outreach, CME conference director, an APP fellowship, and we have a system level executive leadership structure. And I think this model, this APP-led model, works well to provide high quality trauma care because the consistent APP presence and commitment to our protocols and practices really supports that revolving door of residents. And I think this also works because trust and thus autonomy is inevitably built between surgeon and APP. This partnership and really this mentorship importantly leads to high job satisfaction for everyone and has been critical to my path here today. Our team has established, has grown and protected this relationship. And I want to plant a seed today that if you haven't already, to establish it, grow it, and protect it. Another aspect that supports this model is our Trauma and Surgical Critical Care Fellowship for Advanced Providers, of which I was the first graduate in 2011 and served as the program director for 5 years. These photos illustrate the 70+ hour weeks of clinical and didactic time, culminating in a certificate of completion. But what's unique to our program is the requirement of a quality research or a quality improvement or clinical research project. This research project must meet the feasibility constraints of a 12-month program, and yet many of our fellows have gone on to present their work at the podium on the national level and have published in peer-reviewed journals. And it's well known that postgraduate training for APPs provides rigorous and didactic training to produce highly skilled clinicians in any specialty, really. But what people don't talk enough about is how an APP fellowship can really elevate the culture of APPs and residents and physicians and kind of the relationship at the team level and at the institutional level. And I call these the intangibles. Fellowships promote an academic culture that's inclusive of APPs. Fellowships promote a research mindset, a teaching environment, intellectual curiosity. And by the way, these intangibles aren't just available for the trainee, but really is a platform for the entire team, and can really elevate that culture. Tom White founded our program back in 2010 and has understood the value of training and teaming up with highly skilled APPs. And I would venture a guess, to say that it's been a worthwhile investment. And I want to take a minute to talk about one of our APP-led research projects and quality initiatives, because I think it really exemplifies the potential of APP-led research and quality. This is not an unfamiliar scene for a trauma team. I remember taking this photo because this was a resuscitation where everything and everyone worked seamlessly and went well. We know that doesn't always happen in the trauma bay. We got a subclavian line in a matter of seconds and blood was running into the patient before Tom White could breathe down my neck and say, let's go, let's go. And the patient was whisked away to the operating room. And I remember literally just looking at this visual, kind of taking it in, feeling both in awe and grateful for all that was accomplished. Really, a symphony in a moment of sheer disaster. And so around this time, we decided to formally pilot an APP-led massive transfusion delivery process, where we came up with a protocol where the APP functions as the team lead specifically for the delivery of massive transfusion and all parts of that protocol, with responsibilities including assigning support staff roles like the blood nurse and the blood runner, ensuring optimal IV access, proper delivery of coolers and adjuncts, tag interpretation. People are like, where's the trauma APP? I don't know how to read this tracing. And importantly, when in the operating room, communicating with the trauma surgeon and the anesthesiologist, really serving as that liaison to ensure proper delivery of transfusion, avoiding under and over transfusion, and really ensuring adherence to all aspects of the massive transfusion protocol, which really offloads that from anesthesia and allows our surgeons here, Drs. Morris and Majersic, to really focus on what they need to do, which is achieving hemorrhage control. We had noticed that in our hospital and elsewhere in our hospital that the delivery of massive transfusion was really fraught with problems and unfortunately bad outcomes, lack of role clarity. There's just a general discomfort. And so when leadership put their heads together to try to figure out how can we improve care of these patients, the success of our APP-led protocol led to the development of a hospital-wide massive transfusion response team. That's APP-led, functioning like a code team where we respond anywhere in the hospital where there's a massive transfusion activation outside of the trauma ICU or the operating room. And our fellow presented this here back in 2018 at Southwestern Surgical Congress and got to meet the great Dr. John Holcomb. And I can tell you that the experience for her presenting our work on the national stage, of meeting the senior author on the many hemorrhage papers that we scoured, and back home seeing the impact of this work, well, that's the ultimate goal, right? Is to produce and cultivate APPs who understand how far the power of asking questions and the power of that physician-APP relationship can take you in trauma care and, quite honestly, beyond. So now I'm going to turn to my story as an APP in research, which is really centered around the concept of the power of asking questions. This is really rooted in the years I spent as a Montessori kid in a Montessori classroom, where I was taught how to be curious and the value and importance of asking questions all the time. to a fault probably. But whether you're talking about a clinical research question or a patient care question at the bedside, it all has to start with asking the right question. And in the words of Albert Einstein, if I had an hour to solve a problem and my life depended on it, I would use the first 55 minutes determining the proper questions to ask. He, of course, goes on to explain that with the right questions, he would only need 5 minutes to solve that problem. So why VTE? My why is not very compelling, to be honest. It's just that questions around VTE prevention and management were relevant in almost every single patient that I cared for. And VTE historically has been fraught with practice pattern variation, variability, and a lack of consensus. And it seems like over the last 10 to 20 years, the majority of trauma research, at least maybe that I've been interested in, has been focusing on hemorrhage control and clotting and bleeding and clotting, right? This is a clinical dichotomy that's really unique to trauma patients who are at risk for both and often at the same time. And it's not an us versus a them problem. We need to be invested in both sides of this dichotomy because we're ultimately responsible for both. So here's a little story. It was April of 2013 here in this meeting in Santa Barbara, a very, very beautiful place, a very fancy place. It was the opening session, and this moment was the culmination of a couple years of my fellowship and then trauma, working as a trauma PA and long hours on my first ever research project. Hours before my presentation, I was nervously having lunch with doctors Tom White and Sarah Majersic, my trauma mentor, where I sat with my new boyfriend who probably felt like it was some sort of interview. He did pass the test and he's right here in the front row. But Tom asked, do you have your discussant questions all figured out? And I said, what are you talking about? What is a discussant? And he said, who's your discussant? And I said, I don't know. So looking through the program, I saw, oh, Dan Margulies. And he said, okay, geez, I'll just call him. I was a little frazzled. Dare I say, Mr. President, where were you on that one? I had no idea what I was getting myself into, never having attended a scientific conference, but that's okay. Luckily, Dr. Margulies answered his phone. We had our questions in a timely manner. Thank you so much if you're in the room. And we are ready to go. Now, Tom also mentioned in that moment that he thought I was the first APP to deliver a podium presentation at this conference. So now fully understanding the importance and the logistics of this opportunity, I could feel both a weight, pressure, and a lightness of excitement that comes when something special is about to happen. There was one presenter in front of me to learn from. Growing up with a speech impediment did not lend itself to mastery of speaking, let alone public speaking. So knowing there's always little room for word finding error, I had my slides memorized and I was as ready as I thought I could be. But as happens with someone like myself who has imposter syndrome, the doubt creeps in and, I'm not a surgeon. What am I doing here? And as often said by the tennis legend Billie Jean King, and something I've kind of always clung to, pressure is a privilege, right? No pressure, no expectations, no records to set, no award-worthy performance, no finding out what you might have been capable of, no chance to serve, and no time to shine. So that is where it started for me, was looking at enoxaparin. And, at the time, there was really this one-size-fits-all approach. And we were learning that that's not really appropriate for trauma patients for VTE prevention. And we looked at a weight-based regimen in obese trauma patients and found that weight-basing enoxaparin achieved target anti-10A levels in most patients for prophylaxis, and importantly, no bleeding complications. Continuing our quest to hone in on the optimal enoxaparin dose, we undertook a double-blind randomized controlled trial looking at enoxaparin in all at-risk hospitalized patients without anti-10A monitoring. I wrote a grant. I got to work alongside Dr. Majersic, who came all the way from Brown to turn our trauma research program around and basically taught me everything that I know. She put me at the helm as the PI, which landed me at the opening session of the 75th annual AAST meeting in Hawaii. And for an East Coast girl, this was my first time in Hawaii, and I was hoping to be more relaxed, but that's okay. It was beautiful. She put me at the helm, really believing in our partnership. In Hawaii, I felt like this was another first for everyone. For me, I was wondering where all the APPs were and why it seemed like no one had ever seen one in this arena. And for everyone else, they were undoubtedly wondering if the program had misprinted my credentials. Nonetheless, it was a thrill to share our work, and we found that weight-based enoxaparin was associated with reduced in-hospital VTE, although just short of significance. It was exciting, and I really felt like this was signal that was, that contributed to the growing realization that we were underdosing and thus underprotecting our patients against VTE. Years and years of work have gone into this single agent and how to use it appropriately for our patients. And recently, our major associations have put forth some guidelines. And just to kind of boil it down and to simplify it, the bottom line is that for most patients, 40 milligrams BID will be appropriate and is a great place to start. But it's not a one size fits all. There are some who will need more and some who will need less, and you don't want to miss those patients. We can begin with weight, to guide initial therapy. Creatinine clearance should guide the need for closer monitoring. I feel like we didn't think about creatinine clearance soon enough. I mean, the kidneys are responsible for excretion of Lovenox, and creatinine clearance has actually been found to be the only predictor of low and high doses of enoxaparin adjusted by anti-10A. So we must pay attention to creatinine clearance as a red flag for closer monitoring. When I say closer monitoring, I'm really referring to anti-10A levels. And my bias in general is that anti-10A monitoring makes a simple decision more complicated, but it is appropriate and necessary in patients who are extremes of weight and extremes of creatinine clearance. And so after all of that, maybe it's less about the agent and more about the timing. There's this historical perception that bleeding risk long outweighs clotting risk. And a lot of work has been done to address this issue and to evaluate the safety of early VTE prophylaxis. And the story it tells is that bleeding risk, in fact, does not long outlive clotting risk. And we looked at this in a bi-institutional study with Denver in a blunt solid organ injured patients who were admitted to the ICU who were hypercoagulable by TEG parameters upon ICU admission. And I want to share this recent AAST multicenter trial who looked at solid organ injury patients and early versus late prophylaxis. We talked about this earlier this morning in one of the sessions. But what they found is that patients who received early, which they define as within 48 hours, prophylaxis, they do better. They have reduced VTE rates and with no increase in bleeding complications. And that's regardless of solid organ injury grade. But in the spirit of asking questions, why 48 hours? This actually was a question posed this morning. Why not sooner? The authors actually mentioned in their paper that when they moved that threshold from 48 to 24 hours, not surprisingly, the odds of VTE went up from like 2 to 5.2. So remember that sensible prophylaxis can include early prophylaxis, and we need to rethink this concept of what is early. The next important chapter in our VTE journey was in the face of quality. I'm sure everyone has faced this, okay? VTE is a quality marker. I'm gonna make a few points because it's complicated. Number one, quality matters. We can't avoid that. We know that national bodies will impose financial penalties when a hospitalized patient develops a VTE. We also know that not all VTE events are preventable in injured patients. It doesn't really seem fair that a DVT that occurs peri-injury in a patient who gets early prophylaxis should be counted against us, or even as the same DVT event in a patient who gets late prophylaxis or unnecessary missed doses. And then lastly, VTE is an outcome metric. And outcome metrics rely on processes. And there's this assumption that if you can improve your process, you'll improve your outcome. And when you look at effective VTE prevention, it's really a multi-step process. The way I see it, there's risk assessment, then there's prescribing based on that risk, timing, dose, et cetera. There's actual prescription administration, which refers to, missed doses, and then patient acceptance, which has implications, for both inpatient and outpatient compliance. And, there are multiple steps along this process, as we all know, in which adequate VTE prophylaxis can completely fall apart. And is there a point in this process worth targeting to really improve that outcome? I don't have the answer. So if you're on the edges of your seat, you can relax. We need more data to answer this question. And so, as I'm sure we've all felt, hospitals are under pressure to stop looking. And at the time in 2015, our rate was too high. And our administration came to us and said, we got to stop looking. We're an outlier. And so we put our heads together and we thought, is it really okay to just turn a blind eye? How do we reconcile with the discomfort of knowing that DVTs exist, but just not looking for them? Would it be okay if a DVT was missed? And when you have all these questions, you turn to the literature. And the literature was, filled with nothing but disagreement and practice pattern variability. thus equipoise, right? So it was ripe, the research question was glaring, and we were able to undertake the first randomized control trial looking at routine surveillance in hospitalized trauma patients. How do we pull it off? Well, we have a team of 13 APPs. We're all city trained and work with a research mindset because that's the expectation that we set. And on the backs of our APPs, we screened over thousands of patients and enrolled those with a RAP score or risk assessment profile score of greater than 5, denoting moderate to high VTE risk, to receive either routine surveillance or no surveillance. What did we find? What did we learn? Well, we found that routine surveillance was actually associated with significantly lower incidence of PE, and that's always been the hotly debated. Was it clinically relevant, or is it clinically meaningful? And we found a reduced, PE incidence. Not surprisingly, we also found an increased DVT rate in the surveillance group. But what was interesting is that the difference in proximal DVT between the two groups was very subtle and far less than the difference in distal DVT, suggesting that proximal DVT might be a lot less susceptible to the surveillance bias that we hear so much about and might remain an important target for surveillance. And so because of our PE reduction that we found, we have decided not to fully abandon routine surveillance, but really moving forward, we need to somehow optimize it, right? Refine our protocol to optimize the value because people care about value. So how do we do that? Well, one way to do it would be to refine your patient selection. And we looked at this in a secondary analysis and found that the risk assessment profile score was a relatively poor performer in predicting VTE. And why is that? The VTE risks out there and various risk assessment models, of which the RAP score it has been validated in trauma. These were all derived years ago in kind of an older trauma population, and really for the purpose of driving inpatient selection for prophylaxis. Okay, I think that the question here is really a little different, and that selection for prophylaxis has to be somehow different than selection for surveillance. And really, the question is, in a modern day trauma population, in whom patients are getting far more aggressively prophylaxed, in whom is it still worth looking for asymptomatic DVT? Is it the comatose TBI patient who can't, who doesn't have an exam? Is it a certain injury pattern? Is it massive transfusion? Is it TXA? Again, I don't have answers, but we need to work on a new risk assessment approach and model for surveillance inclusion. And then another way to optimize the value would be to replace whole leg ultrasound with proximal leg, which is in theory the more clinically relevant target. So do we even need to look at the calf? And we kind of tried to better elucidate the clinical relevance of calf DVTs, which is really lacking in the trauma literature. And we changed our practice, which was kind of varied, but we did anticoagulate a lot of calf clots. We changed our practice to observation only of distal DVT with serial ultrasound. And we found that this did not impact PE rates. We found that DVT progression was quite low and associated with prophylaxis delay, higher injury severity, and a longer hospital length of stay. All factors that, in theory, you can imagine at the bedside would have precluded the safe initiation of anticoagulation anyway. And so we concluded that observation for distal DVT is probably the most practical approach in most trauma patients. So can we just not look at the calf? And that's really what I'm proposing, but I'll also kind of counter that and say that I do have questions and qualms. While the presence of a calf clot might not escalate your anticoagulation strategy, I wonder if knowing that a calf clot exists affects your kind of overall VTE prevention approach, right? Think about that multi-step process. Are you more likely to be aggressive in avoiding unnecessary missed doses? Are you more likely to push early mobility? Are patients more likely to be compliant if they know they have a clot in their calf with outpatient or even inpatient VTE prophylaxis, all of which might impact clinically relevant VTE? So you're getting a sense, or you're sensing the theme here, and that is we have a lot of questions and not a lot of answers. And with VTE and quality, we're really kind of caught between the fact that quality metrics have to be simple. I've listened to a lot of talks on quality, which honestly are not fun or interesting, but the bottom line is they need to be simple. And VTE metrics or VTE is just not a simple metric. There's so much nuance built into it. Can we get to a risk-adjusted VTE outcome metric? We need more data, but maybe. Experts agree that a combination of a process metric like time to prophylaxis plus the actual outcome itself is probably the best measure of quality. And that's where we should be headed. We still need to better understand the natural history of DVTs. And then we also are understanding and need to better understand the relationship between DVT and PE. we're learning that not all pulmonary clots are the same, right? Some RPEs associated with the DVT, as we've traditionally understood that embolic relationship. But recent data has really suggested that more commonly are primary de novo pulmonary arterial thromboses, which are associated independently with shock and chest injury. And so, if not all PEs are the same, what implications does this have on PE prevention strategies and on PE as an outcome when you're looking at DVT? It's a head scratcher. We need a lot more data. And lastly, what about long-term VTE risk? What do you do when you send these patients home? This is a question with very few answers, and only a handful of authors have really tried to tackle it. Dr. Kornbrunn and his group looked at an all-comers, a group of trauma patients, and found that VTE risk peaked at 3 months and then normalized at a year. So yes, we can stop worrying about VTE after trauma, but not at hospital discharge in most patients. Another group looked at the long-term risk of VTE in TBI patients and found that in severe TBI patients, that risk actually increased over time up to 1 year. Compelling, concerning. There's a lot we don't know. And so with little guidance from our national associations, we decided to try to standardize our approach to post-discharge prophylaxis, as you do if you're trying to look at the effect of an intervention, right? And we created a post-discharge protocol really centered around injury type and pattern, risk assessment profile score, poor mobility, unfavorable dispositions like a skilled nursing facility, and then the presence of a calf clot. First line was a DOAC, plus or minus an aspirin or Lovenox on a case-by-case basis. And we evaluated the impact of this guideline that was really designed to select for patients at higher risk for VTE based on what we know. And we found that patients who were prescribed post-discharge prophylaxis had a similar 90-day VTE rate to those who were not prescribed prophylaxis. So did we just lower VTE rates in a group of higher risk patients to that of a lower group? I mean, that would be great. Or is there no difference between VTE because we didn't accurately or adequately select patients at risk for extended VTE? And my bias is that there is a difference in risk factors for early VTE and extended VTE, and we have yet to elucidate those differences. A lot more to learn. Yeah, right there. A quick plug, you've probably seen this floating around, but the Southwestern Surgical Congress Multicenter Trial has put together a survey. If you take care of trauma patients, this is a survey kind of focusing on VTE practices with a focus on post-discharge prophylaxis, and your input would be super valuable. Okay, so summarizing what I've learned on this 10+ year journey is that VTE research is a long, windy, never-ending road and quest to find answers. Given the low event rate, it takes a lot of patience to adequately power VTE research, and that's just really hard to do. Was it worth it? Yes. The most important concept that I learned in this process is that if variability is the standard, as is often the case with VTE and trauma, be deliberate about your process. It starts with asking a good question. Standardize your care based on the literature or expert consensus. Apply it to your practice, study it, apply the findings to your next clinical research question or your practice, ask a question, and so forth. This is really a never-ending cycle. What is that 30,000-foot view when I think about kind of my VTE experience in the last 10 years and beyond? Well, I think it's important to acknowledge that VTE incidence has decreased, and we should really be celebrating that as a community of trauma providers. And while this is certainly a result of all of the hard work put into VTE prevention strategies, it's also related to advancements in trauma care that have really changed the interface between bleeding and clotting. With improved hemorrhage resuscitation, the period of bleeding risk has really shortened, right? Allowing us to hone in on a much earlier window of opportunity to effectively and safely prevent VTE. Improved trauma care has also I think impacted the risk of DVT in the context of early mobility, facilitated by fewer resuscitation-related complications, getting people off ventilators out of the ICU sooner, facilitated by multimodal pain management, by our ERAS protocols, et cetera, et cetera. So this is just kind of important to remember. We're certainly making progress to better understand and standardize our VTE prevention and management strategies. But how can we more effectively disseminate and more effectively implement the data that is out there? Because that's a problem. And I want to highlight the important work done by this group of multidisciplinary experts at the 2022 VTE Consensus Conference. Look for their consensus publications in the Journal of Trauma and Acute Care Surgery and share these with your colleagues. Looking ahead, we can turn to NTRAP, or the National Trauma Research Action Plan, which was really created to help advocate for funding in high priority areas as identified by experts. 11 panel areas were created, and they generated, through the arduous Delphi process, over 1,000 consensus-based research questions and priorities, really with the goal to guide the next generation of research. So this has been a huge undertaking, and as a research nerd, super fascinating to read through. I want to focus on the acute resuscitation panel, which really focuses on all things kind of inpatient management of the trauma patient, initial evaluation, et cetera. And they identified 4 major themes in terms of where we need to go next. And I want to share those with you. So number 1, determining ideal transfusion strategies, and then specifically looking at permissive hypotension in TBI related to hemorrhage, and then the use of whole blood early and in the pre-hospital setting. Number 2, optimizing VTE prophylaxis. Number 3, evaluating non-narcotic pain control with a focus of ketamine in the trauma bay and beyond. And then number 4, evaluating resuscitative adjuncts. You know, everyone's familiar with the TAP trial. We're looking, TXA. There's a lot going on that we're still trying to elucidate the impact on our bleeding patients. And when we look at their overall top 10 questions of really all things related to inpatient trauma care, 4 of the questions are related to VTE, which is awesome for someone who loves VTE, but also like, oh my gosh, we have so much more work to do. The first 2 questions are looking at TBI. So in TBI patients, what's the optimal timing and agent for chemoprophylaxis, and what's the risk of hemorrhage progression, really, right? And then does early prophylaxis after spine injury and surgery impact VTE rates and or bleeding complications? And these first 2 questions really get at what I call the black box of VTE prophylaxis, which is why I didn't talk about it, because we haven't focused on it. And there just needs to be more focus on this. It's really the TBI patient and the neurosurgical patient. There is a dire need for prospective clinical trials in this patient population, non-operative and operative, in order for us to reach consensus across disciplines. So just an important point there, and where we should be going next. What is the risk of VTE after the administration of TXA? We haven't figured that one out yet. And then in trauma patients who are not fully ambulatory on discharge, for how long should VTE prophylaxis be continued? And what is the optimal agent? And I would add there that factors related to patient compliance should not be overlooked, and that we must incorporate patient engagement into our clinical outcomes as we design future trials. So little did I know that the privilege of that first podium would open a door into a world undiscovered by most APPs. Back then, I remember wondering, where is everyone? My training, my team had taught me that there were no limits. We were at the bedside and beyond. A silver lining, but I soon realized this was all rainbows and butterflies compared to the rest of the world, the rest of the country, where I think APPs were and still are underutilized and underestimated. The silver lining is that being underestimated is like having a superpower. It creates energy. It creates a challenge that cannot be shied away from if one is passionate about the mission. Being underestimated creates an incentive to work harder. It creates momentum for change. To the highly recognized surgeons who are moderating an opening session and can be heard muttering, "This PA better be good," challenge accepted. To the discussant who was visibly confused that I was a lead author and presenter, presumably because of the credentials behind my name, thank you for allowing me to break down a barrier, and for your email hours later offering me a job on your team anytime. I have met many APPs across the country, and in this organization, in this room, who function at the top of their scope, who go above and beyond their shift work to advance their surgical programs, all of whom come with supportive surgeon partners. Seek them out and pick their brains. I want to acknowledge one of our own, Lindsay O'Mara, a nurse practitioner from Maryland Shock Trauma. She's blazed quite a trail with her team of surgeons and APPs who are all sitting right there. She was the first, I think, APP to lead an East multi-center trial and has turned heads with her research mindset and her academic presence. She has been my co-captain in advocating for advancing the surgeon APP partnership in trauma and EGS. Together, we are ACS. So the most common question I hear is, how do you retain APPs? Like, we hire them and then they're out the door a year later. What is your secret sauce? And I think our story and our model is really accessible to anyone if you could understand the recipe. So what is that recipe for success? And the way I see it, APPs need to be seen as valued clinicians and colleagues, kind of first and foremost. Goes without saying, but it's important to believe that and build a team around that value. Build a team that promotes autonomy, critical thinking. We want to be challenged. We love the floor work, but we want to do everything else. So challenge us and create an environment that's equitable with residents. Create or cultivate an academic culture that includes APPs. Promote a culture of asking questions of each other, of the evidence. This will help to support that research mindset that's really critical for all of us to maintain, and that growth mindset for your team. Encourage APP participation in grand rounds, journal clubs. Start a fellowship. Advocate for protected time, which will demonstrate a commitment to APP involvement beyond clinical care. And I promise you, this will support engagement and job satisfaction in a way that will promote retention. And lastly, come join us. We're fun. Attend annual scientific meetings and ensure adequate time and CME money to do so. If we can do it, you can do it. We can, what does an optimal model look like to you? Not dissimilar from Lovenox, if I may. One size does not fit all, right? We can all agree that APPs are needed to support ACS programs at the bedside, but what does that look like to you? And I hope that today you leave with a slightly broader view of what's possible and what it could look like for your team back home or for your future back home. Think beyond the bedside and think outside the box. We can brainstorm for a second. Do you want to start a fellowship? Do you want to grow your research program? Do you want to beef up your PI or QI efforts? Do you want to improve your transition to practice curriculum or maybe resident education? Do you want to expand your surgical clinic? Do you want to grow injury prevention and outreach initiatives? On and on. There's an APP, Brad Morris in the front row for that. For me, it started with a fellowship, and it started right here with this organization. You are a community of surgeons and trauma providers who aren't necessarily PhDs, but who through thousands of hours at the bedside and in the operating room have chosen to go a step further. You ask questions, you push boundaries. You're sitting here because you're willing to leave your families and your workplaces to learn something from someone. You provide a network, and you are passionate about advancing patient care. By showing up here, we are showing up for our patients, and that energy is infectious. The opportunity to be a part of that undoubtedly changed the trajectory of my career as a PA and could impact your APPs back home. To this room, to this organization, you have been a leader in advocating for APP incorporation at the scientific level. You have pushed for membership growth and have provided a seat at the committee table, the moderator table, and even the dinner table. To my team back home, many of whom are sitting right here, if I look at you, I might cry. I'm here because of you. I'm a product of our partnership, your friendship, and most importantly, your mentorship. It's really just that simple. To my research partners in crime, Dave Morris, Tom White, Sarah Majersic, who have spent countless hours poring over questions and drafts of papers, who have never set limits on what we can accomplish together. You've taught me so much about patient care, clinical research, but importantly, to believe in myself. Thank you for your hard work, your guidance, your patience with my questions, and your commitment to our partnership. I'm confident that soon will no longer be the exception, but the rule. To Zach, my husband and father of two adorable little humans, who, as you know, has witnessed this journey from that first awkward lunch. Thank you for never questioning the why behind this mission of mine, for never doubting that all the unpaid work hours spent and sleep hours lost were 100% worth it and were necessary part of my process. To the surgeons and APPs out there, don't underestimate what you're capable of together. As Dr. Morris likes to tell us back home, the whole is greater than the sum of its parts. We are better together. We can go farther for our programs and for our patients. So let this be your call to action. Let this be our shared vision moving forward. Here's your dopamine shot. One of my other great passions is being outside, preferably with skis under my feet or on my back in this case. This is a picture from Chamonix, France, and I feel like really captures this moment for me and for us. The moment when you stop for a second to catch your breath and you turn around and you see where you've come from. Along the way, the mission hasn't felt or didn't feel that big. And in fact, for me, there was never a particular summit in mind. It was just one question, one patient, one idea at a time. And all of a sudden, you notice how far you've come as a team and as an individual, that a distance really sinking in for the first time. I hope you leave here today with a newfound idea of what you're capable of, with the realization that if we can work together, you too can turn around one day and realize how far you've come for your programs, for your patients, and for your communities. And in closing, Dr. White provided a wonderful summary of Dr. Poth, and I also dug into his legacy. And I just want to acknowledge it's an honor to speak up here in his memory. And as I read about him, I couldn't help but feel connected to his path, really driven by nothing more than an innate passion for asking questions, for conducting research, for writing, for collaborating, and for pushing the art and science that we call practicing medicine to new levels. Thank you.
Any questions? Any questions for Annika? Come on, there has to be some questions.
What's the beauty of this?
Well, I know there's a few questions out there and the answer is no. No freaking way. No matter, no amount of money, no enticements. She's ours. She's never going to be yours. Find your own, foster your own. No, the answer is no. Okay. Annika. Pretty sure. Okay. Thank you, Nika. Outstanding. All right. We have a little bit of a break. The next scientific session, session 6 is question. Oh, I'm so sorry.
Hi, I'm Sarah Soul. I'm trauma faculty in Memphis. I love the idea of you being part of helping to guide the MTP, especially with the summer coming up in Memphis. Not infrequently, we have 3 and 4 shock trauma ones going on in the trauma bay, and they're all getting MTP because everyone is shooting each other. So I'm curious to know, how did you guys get trained up to where you felt comfortable throwing in a subclavian or whatever in these scenarios? And how did you guys sort of set time aside to do that?
Yeah, great question. Thank you. I joined a team in 2010 that had been doing that for over 10 years. So, you know, with an APP led model, we've been in the trauma bay for years. And so that, that picture I showed you, kind of was like, we are experts at this because we've been doing this in our APP led model for years. Our APPs who'd been on the team were facile at doing these procedures, at being team lead for resuscitations. And so we have that expertise. And it just kind of happened, through our model. And when we realized that we are, the trauma team, we are the blood experts, let's help anyone else in the hospital who's bleeding. Our APPs, supported by our surgeons, felt like we could run an MTP. And that required some kind of relationship building with anesthesia, as we were kind of walking into their territory, among other ICUs. But pretty quickly, people were like, where's the trauma APP? So I think it was really a nature and a product of our model, culminating in this response, a team. So it wasn't really time set aside. It's just how we were operating, so to speak. I don't know if that's a good answer or helpful, but we can chat more later. Thank you.